This presentation, the role of toxic metals in cardiovascular and renal disease, was given at the fall 2017 meeting of ACIM, the American College of Integrative Medicine. ACIM is led by Dr. Lee Cowden. Dr. Cowden's goal is for every physician in the United States to become an integrative physician. It's okay to use drugs in surgery. I use drugs in surgery all the time. I've done over 10,000 invasive procedures, and I continue to send my patients, when needed, for angiography, stent placement, bypass surgery, and other interventions. This is okay, but it is not sufficient. We must also include in our armamentarium diet and lifestyle change, nutritional optimization, detoxification, and other health-promoting measures. We need to promote health and not just react to disease. If not, we're going to get sicker and sicker, and we're going to be spending more and more money as we get sicker and sicker as individuals and as a society. Every doctor needs to become an integrative doctor. That's Lee's goal, and I'm doing my best to help him. Lee's formal training is in cardiology, same as mine, and over the years we've become personal and professional friends. Decades ago, Lee saw that standard cardiology, drugs and interventions, were dealing with crises, but this approach wasn't preventing the crises. Lee got involved in integrative medicine and in the training of other practitioners. His organization, ACIM, offers quarterly training meetings in which I participated both as a student and as a teacher, and there's a national meeting once a year in which this talk was given. ACIM's administrative director is Ann Sconyers, whose husband Gary is an internationally recognized naturopathic physician. The Sconyers practice in Dallas and they work closely with Dr. Cowden, and from time to time my patients will see them. When you see the Sconyers, you spend a week and you undergo a thorough evaluation. One of my patients was planning a week with the Sconyers, and his daughter was home for spring break. Her school got out at an unusual time, and none of her friends were going to be home, so she had a week with nothing to do, and as it's warmer in Dallas in March than it is in Detroit, she traveled to Dallas with her dad. Well, she's a rather attractive young lady, and the Sconyers have a son the same age, and he sometimes helps out at the office, so it was only natural they went on a date. The date went well, and they went on another date, and a year later they got married. So now whenever we call the Sconyers, we identify ourselves as the daughter-in-law referral practice. When I gave this talk, my audience was a room full of like-minded integrative practitioners, and I had 70 minutes, and I went pretty fast. Most of you listening to this presentation are not physicians, and much of what I say may be new to you. But with this format, I have the luxury of time, and I'll do my best to explain the key points. Also, these topics are all covered in greater detail on our other presentations, available at the office or on heartfixer.com. At this point in my career, I spend 90% of my time working with patients, 5% teaching doctors, and 5% in research. Pertaining to this discussion, I was a principal investigator in TACT 1, which studied the use of magnesium EDTA Chelation therapy in heart attack survivors, and we're currently involved in TACT 2, a follow-up study confined to diabetics who have experienced a heart attack. I'm going to begin our discussion of the role of toxic metals in cardiovascular and kidney disease by presenting our most important clinical trial, TACT 1. TACT is the trial to assess chelation therapy. We took just over 1,700 subjects. They were all clinically stable without a recent revascularization. They were at least 6 months out from their first heart attack. On average, they were 4.6 years out from their first heart attack. A third were diabetic. 40% had a larger anterior infarction involving the front wall of the heart. And within the TACT protocol, all the subjects received standard post-infarction, post-heart attack medical therapy. 73% were on statins. Their mean LDL was 89. Their mean fasting sugar was 102, so their sugar was under pretty good control. 84% on aspirin, 72% on a beta blocker, 63% were on an ACE inhibitor or an angiotensin receptor blocker, and 83% had a prior revascularization, either a balloon angioplasty or stent placement. So what we did, all 1,708 subjects received 40 IV treatments over a year and a multivitamin randomized as 1/2 received IV EDTA Chelation therapy, 1/2 received a placebo solution, a bag of salt water, 1/2 received a high-potency multivitamin. This is a broad-spectrum 6-a-day vitamin and mineral supplement designed to minimize oxidative stress. the antioxidant vitamins don't prevent the generation of oxidative stress, but they will neutralize the free radicals. So antioxidant vitamin minerals neutralize oxidative stress. And half received a low potency multivitamin. So 25% of the patients received EDTA and a strong multivitamin. Our theory is that oxidative stress drives cardiovascular disease. By removing heavy metals, which are a cause of oxidative stress, we're decreasing the generation of free radicals. With the multivitamin, we're neutralizing any free radicals that are generated. 25% got double active therapy. 25% received EDTA and a weak multi, simply enough minerals to make up for minerals that might be washed out in association with the chelation process. 25% received an IV placebo and a strong multi, 25% received double placebo. So we could look for the independent and synergistic effects of chelation therapy, removing metals that cause oxidative stress and vitamin mineral supplementation to neutralize free radicals that are generated. We looked at primary endpoints and secondary endpoints and followed these patients for 5 years. 38% of the patients that received placebo therapy experienced an adverse event, death, heart attack, stroke, coronary revascularization, or hospitalization with unstable angina over 5 years, which is pretty much what you'd expect. These patients had all had a heart attack, and we would expect them to have recurrent problems. 38% event rate over 5 years was expected. In the subjects that received chelation therapy, the event rate was 33%. So there was an 18% risk reduction that was statistically significant, showing that chelation therapy, when added to standard medical therapy, decreases adverse event rate. Now you'll notice nothing happened for a year, and then the event rate curves begin to separate, and they continue to separate over time. Why did nothing happen early on? Because it takes time to turn the ship around. If you have high blood pressure and I give you a drug, your blood pressure may fall in a few days. But if you have atherosclerosis due to decades of untreated oxidative stress, to remove the cause of this undue oxidative stress, removing metals, it took you decades to fill up your bone marrow with toxic metals and your soft tissue with toxic metals. It's going to take time to remove them. So when we are removing the cause of disease, this is a slow process, but we're slowly and persistently resolving the oxidative diathesis, the oxidative predisposition to atherosclerotic vascular disease. This takes time. All components of the primary endpoint were lessened: death, heart attack, stroke, need for repeat revascularization, and need for repeat hospitalization. With multivitamin therapy alone, so you're getting placebo IV and either double placebo or the active vitamin, there was a 3% risk reduction. This was not statistically significant by itself, but it supports our theory. And again, nothing happened for a year, and then the event rate curves begin to split. Now, the worst outcome was double placebo. They had the highest event rate. The best group, the best outcome was double active therapy, and this makes sense. We're removing the metals that generate undue oxidative stress. We're giving you vitamins and minerals to scarf up any free radicals that break through. You would anticipate there would be a synergy here, and indeed there was. The best outcome was chelation therapy with a high potency vitamin mineral supplement. Now, those that had anterior infarctions, anterior wall heart attacks involving the left-hand ascending distribution, they lost more heart muscle, they are at greater risk for an adverse event, and here chelation provided a greater degree of risk reduction. 37% 5-year risk reduction. As a general rule, the larger the heart attack, the worse the natural history, the greater the upside potential, and the more powerful impact will any therapy have. So overall, there was an 18% risk reduction in those that had the larger anterior heart attacks. There was a 37% 5-year risk reduction. The natural history of diabetics is worse than that of non-diabetics. If you're diabetic, you're generating a great deal of undue free radical stress, and chelation therapy lowered 5-year event rate in the diabetic patients by 39%. Now, death rate fell by 43% with chelation therapy in the diabetic infarct survivors versus the diabetic infarct survivors that received placebo therapy. This is the event rate in the diabetics. It was nearly 50% at 5 years. Vitamins alone had no effect, and that's because the vitamins alone were not sufficient to neutralize the oxidative stress generated by being diabetic and having a heavy metal burden. Chelation, though, was quite effective, and there was tremendous synergy in this group. The best outcome was chelation therapy and high-dose vitamins. Again, there's a greater upside potential in the diabetics because they're generating free radicals. They have a metal burden. If we remove the metals and provide antioxidant vitamins, we're going to get the best outcome. So there was great synergy here. So synergy between metal detox and antioxidant support in the trial to assess chelation therapy, supporting our theory that oxidative stress is the key driver of atherosclerotic vascular disease. So EDTA chelation works in chronic coronary disease. This has now been demonstrated. How does it work? Which steps in atherosclerosis are attenuated? Which steps are not? What are the optimal concomitant therapies? Will metal detox and oxidative stress reduction benefit other organ systems? This is EDTA, a hexadentate chelator. We administer EDTA. It binds a metal in its active site, and then the EDTA metal complex is excreted either in the urine or through the liver. Let's talk a little bit about the steps of atherosclerosis. Atherosclerosis begins when lipid particles enter the artery wall at sites of intimal activation and vulnerability. You have endothelial dysfunction, the vascular wall is more porous, the lipids can enter. That, of course, is not pathologic because every cell of the intima has an LDL receptor. LDL cholesterol is food. If the LDL does not bind an LDL receptor, it can swim right out, unless the lipids are retained. Phospholipases, which are upregulated in the presence of systemic inflammation, will minimally oxidize the phospholipids of the LDL, and then they clump together and they get trapped on proteoglycan that is composed of chondroitin sulfate. They're trapped, they can't swim out, and then free radicals generated by all the cells of the intima will oxidize the LDL, creating a protein structure not normally present in the human body. We are not tolerant to oxidized LDL. It is interpreted by our immune system as a bacterial invader, and thus we mount an acquired, skewed immune response against pseudoinfection of the artery wall with oxidized lipids, and that's the driving force of atherosclerosis, when lipids become oxidized by excessive free radicals. Over the years, the vascular wall will thicken with progressive deposition of lipids, progressive infiltration of mononuclear cells, monocytes that become macrophages. Systemically, we see an increase in the generation of Th1 and Th17 immune inflammatory cytokines, immune mediators, and we see a reduction in regulatory cytokines. So the immune system is now in battle mode. We're not quieting things down. We think that we're experiencing a chronic bacterial infection of the vascular wall, but it's really a pseudo-infection with oxidized lipids, and our immune system generates all these inflammatory cytokines that generate more inflammation, more oxidative stress, and the plaque thickens and becomes unstable. Finally, we have the terminal event at a shoulder region of the plaque, a region that is characterized by excessive oxidative stress, matrix metalloproteinases elaborated by macrophages under the influence of interferon gamma, released by activated T cells, will be processed by chymase released by activated mast cells, and then you'll degrade the fibrous cap. The atherosclerotic gruel will flow out into the flow lumen, and you'll have a heart attack. And this is really an acute, severe imbalance between the ability to neutralize free radicals and the generation of free radicals. We have plaque rupture and oxidative inflammatory bonfire. We want to prevent this. And if we're going to prevent this, we need to deal with the causes, the risk factors, the abnormalities in vascular biochemistry and cell biology that allowed this process to begin and which allows this process to progress and perpetuate. And of course, key here is oxidative inflammatory stress. I can present to you atherosclerosis as a maladaptive response to the immune system, what it perceives as infection of the artery wall, with oxidized lipids, and this is a skewed immune response characterized by Th1 and Th17 upregulation. And oxidative stress is required to initiate this process. More recently, we're learning that cells of the innate immune system will respond to the presence of crystalline cholesterol in the vascular wall as a danger signal. So unstable angina is very similar to acute gout, and we can block that with colchicine. Again, oxidative stress is needed to prime this sterile inflammatory response once either the sterile inflammatory response of the innate immune system or the acquired Th1, Th17 dysregulated immune response gets going. There's going to be a further outpouring of oxidative stress. Oxidative stress can be thought of as the kindling and the bonfire of vascular inflammation. Oxidative stress, too many free radicals that outpace our ability to neutralize them with our endogenous antioxidants. We get lipid oxidation, and we get oxidative stress, and then we get the oxidative bonfire, which is a heart attack or unstable angina. Why is this occurring? Because Mother Nature interprets oxidative stress as infection. Our natural predator is infection. Whether you believe in creation or Darwinian evolution, we have been evolving. In over 4 million years, we become adept at recognizing and responding to infection, and primitive man would experience oxidative stress only as a consequence of infection. So when we experience oxidative stress, we go into defense mode and we think we have an infection. So we're going to make free radicals. We're going to mount an inflammatory response. The vascular wall will activate so white cells can adhere to the vascular wall and get into the tissues to kill microbes. We're going to make cholesterol because our white cells need cholesterol for cell membranes. If we're going to mount a defense, our blood sugar goes up because the white cells need sugar. So these phenomena that characterize cardiovascular disease is really a maladaptive response of our immune system to what it thinks is infection. Now, let's talk a little bit more about the pathogenesis of cardiovascular disease. LDL, LPA, and remnant particles, these are lipid particles that contain LDL protein, apolipoprotein B1. They're going to traverse the endothelium at sites of vulnerability. Now, this is going to be beyond branch points where instead of laminar flow, there's oscillatory flow, kind of like the bend in the river, and you get flotsam and jetsam at these beyond the bends. And with this irregular shear stress, we make less nitric oxide, we make fewer antioxidants, so this is our weak point. And this infiltration of the vascular wall will be more likely to occur if we have high lipid levels, particularly if they're small particle size so they can wiggle through the junctions between the endothelial cells. And this is going to occur at sites of endothelial dysfunction, intimal thickening, oxidative stress, high blood pressure, and as we're going to see, toxins, metals, and organic pollutants predisposed to lipid infiltration of the vascular wall. Now, we vilify cholesterol as the cause of heart disease, but every cell in our body needs cholesterol. We need 800 milligrams of cholesterol a day to make vitamin D, steroid hormones, cell membranes. If we're going to mount a legitimate immune response and make more white cells, the white cells need cholesterol for their cell membranes. So we depend on 800 milligrams a day of cholesterol. If we don't get enough from our diet, the liver will generate cholesterol. Cholesterol is water and thus blood insoluble. It's a waxy substance. So Mother Nature binds it to a protein, apolipoprotein B1, to form up the blood-soluble LDL, and its job is to carry cholesterol to the cells of the artery that needs it. We also have measures to take excessive or unused cholesterol back to the liver, and this would be the HDL. That's the good cholesterol that mediates reverse cholesterol transport. Now, we can return cholesterol to the liver for degradation into bile salts via HDL, and the enzyme on HDL is called LCAT, lesser than cholesterol acetyltransferase. What it does, it takes a fatty acid from the second carbon of phosphatidylcholine, tacks it onto cholesterol to make a cholesterol ester, loads it up on the HDL, and takes it back to the liver. So we will use phosphatidylcholine therapeutically, particularly unsaturated phosphatidylcholine with two linoleic acid molecules to stimulate reverse cholesterol transport, and this has been shown not just to lower cholesterol, but to reverse atherosclerosis. The most important determinant of your serum cholesterol is the status of the LDL receptor in the liver. When the liver needs cholesterol, it will express the LDL receptor. It will pull cholesterol out of the blood and degrade it. So if we want to lower your cholesterol, we want your liver to express the LDL receptor. The expression of the LDL receptor is tightly regulated by this system within the cell. When our cells contain a cholesterol sensing molecule called INSIG, and when INSIG thinks there's enough cholesterol in the cell, it will sequester SREBP, sterol regulatory element binding protein, in abeyance in a region called the endoplasmic reticulum, where it's inactive. If INSIG senses that there's not enough cholesterol in the cell to meet the needs of the liver and thus the needs of the body, it will fall apart and scap sterol regulatory element binding protein, cleavage activating protein, will snip some amino acids off SREBP, allowing it to transport into the nucleus and read the genetic code and make more LDL receptors. So under normal circumstances, we're going to make LDL receptors in the liver and on all of our cells only when we need it. This situation is why your cholesterol is normal when you're a kid, but this regulatory mechanism will be compromised by inflammation, oxidative stress, and toxins to help explain why your cholesterol was normal when you were 25, when you were eating pizza and drinking beer. It's not normal when you're 40 and 50, 60. You're working hard to lower your cholesterol. You're watching your diet. Nonetheless, your cholesterol is rising, and that's because you've accumulated oxidative stress, inflammation, belly fat, organic pollutants and metals. This feedback mechanism has been disturbed, and your lipids are rising. So our hypothesis is that one of the reasons we have hyperlipidemia is because we have a toxic burden. Some of it is our diet, some of it is leaky gut, some of it's organic pollutants, but some of it's metals. Hal Huggins, who was the very first dental practitioner to recognize the dangers of mercury filling, and he was the first dentist to advocate amalgam removal, he showed that if you remove amalgams and supplement patients appropriately with nutrients, cholesterol will fall. A paper published before I was born showed that oral EDTA will lower cholesterol. Now, oral EDTA is poorly absorbed, but they used very, very high doses, 1,000 to 2,000 milligrams a day, and they showed that cholesterol would fall from 257 down to about 190. This is one of my own patients. We carried out a provocative challenge. I'll talk about this methodology a little bit later. We administer a panel of chelators and see what metals come out in the urine. This is our best measure of your soft tissue metal burden. Most of the metal is in your bone where it's not bothering you, but the metal in your soft tissues, your arteries, your kidney, your liver, your heart, those are the metals that are compromising your biology, and our best estimate of your soft tissue metal burden is the results of a provocative challenge. She had a mixed burden of different metals. This patient refused to take any cholesterol-lowering drugs. She wasn't going to do it, but she allowed me to chelate her, and we treated her with EDTA to get lead and cadmium. Her cholesterol fell. Then we added in DMPS to get mercury. Cholesterol fell further. So in this individual, part of her hyperlipidemia was due to metal overload. This is a man, a 64-year-old athletic man with atrial fib, mercury fillings, cholesterol 277. We got rid of the mercury fillings, nutritional supplements. We treated him with DMPS, which is a mercury chelator over 6 months. His red cell mercury level fell dramatically. Your red cell metals reflect what's been in your blood the last 3 months, kind of like the relationship between hemoglobin A1C and blood sugar. It doesn't reflect your body burden precisely, but what has been floating around in your blood. So his mercury level fell, and his cholesterol fell from 277 to 235, his LDL from 186 to 121. We were pleased with that. So we've demonstrated that metals are playing a role in hyperlipidemia. But hyperlipidemia alone is not enough to cause heart disease. Could metals be playing a role in endothelial dysfunction and intimal thickening? Could metals be rendering our vascular wall more porous to allow these lipids in? This study looks at the relationship between cadmium burden and carotid intermediate thickness. 195 ARFI participants. This is the atherosclerosis risk factor in female youngster study. These are our daughters and our granddaughters, college kids, age 18 to 22, in overall good health. You're going to record carotid artery intermediate thickness. Here we do an ultrasound of the carotid artery. We're not looking for plaque. We're measuring the thickness of the artery wall. The thickness of the artery wall in relation to age and gender reflects your propensity to form plaque. If you have a high IMT, it means that you are a plaque former. These young girls aren't at risk for having a heart attack now, but if their IMT is high, they're at far greater risk of getting into trouble in their 40s, 50s, and 60s versus their age-related colleagues with a lower IMT. So a high IMT reflects your propensity to form plaque. A high IMT is a bad sign. We're going to treat you and we will try to regress your IMT. Well, they said if you were above the 90th percentile that you had a high IMT, and 17% of these girls had a high IMT in compared to age and age-related population controls. They measured serum cadmium and zinc levels. Now, your serum level is not a great indicator of body burden, but it is an indicator, and it's an indicator that's easy to measure, so they use serum cadmium and zinc in this study. Look at standard risk factors, and then we're going to look at the risk factor adjusted risk of a high IMT in relation to cadmium level. Will high cadmium predict a high IMT? So what they did, the risk, your relative risk of having a high IMT being in the top 10% in relation to tercile of cadmium. So the girls in the lower third for cadmium were in the first tercile, middle third, second, upper third were third. And you can see as you go from the first to the second to the third, your risk of having an IMT rises sixfold. Now, we grow our tobacco in North Carolina and Virginia because the soil is high in cadmium. The tobacco plant likes cadmium. So if you're a smoker, you're going to have high cadmium. So they repeated the assessment, and they excluded the smokers, and they saw that the link between high cadmium and high MT was even greater. We're getting cadmium in our environment, in our food, in our water. It's the product of many industrial processes. So we get it from smoking, and we get it from simply living in Western society. Now, if you were low in zinc, if you were in the first or the second tercile for zinc, as cadmium goes from the first to the second to the third tercile, your risk of a high MT increases. But if you were in the upper tercile for zinc, the cadmium effect was neutralized. The message here is that cadmium depletes zinc. Zinc neutralizes cadmium. They're competing with one another. So high zinc was protective against the adverse effects of cadmium in this patient population. So of course, in our vitamin mineral supplements, we're going to recommend zinc because everybody I see has some degree of cadmium overload. We're not supposed to have any, so I'm going to recommend some degree of zinc supplementation for everybody I see. Now, this was an in vitro study. They took animal blood vessels and they dribbled either zinc or cadmium on the luminal surface. That's the surface of the blood vessel adjacent to where the blood would flow. And they found that cadmium caused the vessel wall to be permeable, leaky. So we think that if you have cadmium on board, your blood vessels are leaky. That makes it easier for lipids to cross into the vascular wall. And this was neutralized with zinc. These are endothelial cells, cells that line the artery wall. In tissue culture, if you add in cadmium, you can see they begin to die. They don't look so good. Zinc doesn't hurt anything. And then in this situation, zinc neutralized the adverse effect of cadmium on the health of the endothelial cells. Now, this is an animal study. ApoE double knockout mice do not have LDL receptors. They will have hyperlipidemia, they will have atherosclerosis, and if you treat them with cadmium, they have more endothelial dysfunction and endothelial death. Their cholesterol rises even further, and they have more plaque. And in this model, zinc was not protective, so cadmium aggravated atherosclerosis in the ApoE double knockout mice, and this is a reasonable surrogate for human atherosclerosis. So far, phenomenon that aggravate atherosclerosis in ApoE double knockout mice or LDL receptor double knockout mice aggravate atherosclerosis in humans. Things that are therapeutic in this model are therapeutic in humans. So this is more evidence that cadmium will have a deleterious effect in humans with cardiovascular disease. So we've shown that in young people, our kids and grandkids, high cadmium simply being in the upper tercile for young ladies is associated with a high IMT and an increased future risk of cardiovascular disease. We've shown that cadmium causes the endothelial cells to be porous. We also know there's a link between cadmium and inflammation, and that's because cadmium causes oxidative stress. Anything that causes oxidative stress causes an inflammatory response. If we go from the first to the second to the third to the fourth quartile for cadmium, we see in lockstep a rise in C-reactive protein, a rise in fibrinogen, both inflammatory mediators. High CRP, high fibrinogen are associated with an increased risk of cardiovascular disease. So cadmium effect in humans: intimal thickening, endothelial activation, systemic inflammation. Cadmium in vitro endothelial effects: increased permeability, decreased proliferation of the cells, decreased survival of the cells, DNA double-strand breaks, apoptotic cell response, the cells are committing suicide. We don't want this. And when I do red cell studies of my patients, most often I see high cadmium. When I do provocative challenge studies, I often see high cadmium. We have a cadmium overload, we have a lead overload, we have a mercury overload, and we have an aluminum overload in our society. So metals are playing a role in hyperlipidemia. They're playing a role in endothelial dysfunction, intimal thickening, making the vascular wall porous, allowing the lipids in. But still, that's not a problem because LDL cholesterol is food. LDL is a protein, apolipoprotein B100, containing a sac of cholesterol and triglycerides and cholesterol ester. The outer wall of the apolipoprotein B100 is studded with phospholipids. And the rheologic characteristics, the flow characteristics of the LDL, depend upon the quantity and quality of the phospholipids in its outer wall. But every cell of the intima needs LDL. Every cell has an LDL receptor. If the cells don't need cholesterol, they withdraw their LDL receptor. Remember, we have that SCAP-SRE interaction. If the endothelial cells don't need cholesterol, they're going to withdraw their LDL receptor. So if there's no cells with an open LDL receptor, the LDL will wash out of the artery wall unless it is modified and trapped. Now, what happens is phospholipases like phospholipase A2, phospholipase D, liporodipase that are activated in the presence of systemic inflammation will oxidize the phospholipids coating the LDL, and then they'll clump together. And they clump together and they bind to chondroitin sulfate in proteoglycan, the ground substance of the artery, and they're trapped and they can't get out, and then they're subjective to oxidative stress. So phospholipase A2 breaks one bond, phospholipase D makes another bond, making lysophosphatidylcholines, which are inflammatory in nature. So here we're going to look at phospholipase D activation in bovine, that's cattle-derived endothelial cells. And here we will see that if you incubate these endothelial cells with 3 different species of mercury, mercury chloride, methylmercury that you would get from fish, thimerosal, which is in vaccines, you can see that there is a dose and time-related activation of phospholipase D, suggesting that mercury will activate phospholipase D, causing minimal oxidation of the phospholipids of the LDL, causing them now to clump together on the chondroitin sulfate proteoglycan and get trapped. Now, vitamin C will to some degree attenuate mercury-induced phospholipase activation. Vitamin C will squelch superoxide. Mercury causes oxidative stress to generate superoxide. A more effective therapy is N-acetylcysteine, which contains a thiol group, a sulfhydryl group, and N-acetylcysteine supports glutathione. Glutathione is a specific chelator of mercury, so you can see that N-acetylcysteine was more effective than vitamin C because it upregulates the generation of glutathione, which will bind and remove mercury. EDTA, a strong chelator of lead, aluminum, and cadmium, blocks mercury-induced phospholipase deactivation to some degree. DMSA, a specific mercury chelator, does a better job. So if you remove the mercury and if you generate glutathione to help remove the mercury, you'll block mercury-induced phospholipase activation, at least in this animal model. And we want to do that because if we have hyperlipidemia, if we have a porous, leaky vascular wall, if the lipids are minimally oxidized and trapped on the proteoglycan, they can't swim out, they're stuck there, and they're subject to oxidative stress by free radicals. A free radical is an atom with 1 as opposed to 2 electrons in its outer shell. It is unstable and reactive. It'll snatch an electron from the next atom, quenching its thirst, but forming a new radical. And one by one, all the atoms will be damaged, the cell will be damaged, the organ will be damaged, and we get sick. Atherosclerosis and all of our age-related degenerative diseases are driven by oxidative stress. Where do these free radicals come from? Well, within the vascular wall, enzyme systems of the normal cells of the vascular wall, the endothelial cells, resident white cells, the macrophages, vascular smooth muscle cells, will all generate free radicals via their housekeeping enzymes, such as NADPH oxidase, xanthine oxidase, angiotensin converting enzyme, cyclooxygenase, myeloperoxidase. We'll talk about them a little bit later in other talks. If we call in mononuclear cells to investigate this irregularity that Mother Nature is noting, this potential infection, they're going to make free radicals. But the big problem, the pathological source of oxidative stress in the vascular wall, is our burden of heavy metals and organic pollutants. So these lipids, once they're trapped, they're subject to undue oxidative stress. And this creates oxidized LDL, the driving force of atherosclerosis. The immune system recognizes oxidized LDL not as food, but as a microbe, and we will acquire a chronic inflammatory response. The atherosclerotic plaque is a slowly growing boil that eventually ruptures and causes a heart attack. If we look at your relative risk for having a cardiac event, if you're in the second or third tercile for LDL versus the third, of course it rises, but it rises a lot more with oxidized LDL. Oxidized LDL is a strong predictor of a rising IMT, which in turn reflects an increased predisposition to disease progression and event rate. So we need to block LDL oxidation. So I learned about oxidative stress 20 to 25 years ago from this guy, Terry Chappell, who practices in Bluffton, Ohio. Now, at this time, 25 years ago, I spent all my time in the hospital, and I was actually tied at age 35 with 2 older guys as the leading admitter of cardiovascular patients to my primary hospital. The coronary care unit had 8 beds, and one Tuesday afternoon, 25 years ago, between 2 and 4 in the afternoon, all of all 8 charts corresponding to those patients had a blue sticker showing they were Roberts patients. I spent all my time taking care of crises, doing invasive procedures. I was sort of a master of cardiovascular disaster, but I wasn't doing anything to prevent this disease. And then one day, this little old lady got admitted to me with a small heart attack. I did her heart cath, and all 3 vessels were blocked. And I advised her to undergo bypass surgery before she left the hospital. And that was a fairly bold recommendation because at that time, the standard was to medicate the patient, have them go home and recover, and have their bypass surgery a month later because surgical anesthesia then was not as well developed as it is today, and the mortality with acute heart attack surgery was quite high. But the blockages were so tight that I was really worried about this lady, and I said, you need to have the bypass surgery. She didn't want to do it, so I said, ma'am, if you don't have bypass surgery before you leave the hospital, you're going to die. Well, she listened politely and declined my recommendation and went home, and I put her on a beta blocker, propranolol. I saw her in the office a few weeks later, and I told her, I hope you've made up your mind to have surgery because you're at risk of death. Well, no, I need a little bit more time. My family's coming in. Well, okay, take this diltiazem. I saw her a month later, and I told her that she was going to die without bypass surgery. Oh, I just need to wait a little bit longer. So I would see her periodically and tell her that she was going to die without bypass surgery. And then about 2 years later, I was going in to see her, and I was getting ready to tell her she was going to die without bypass surgery. And it dawned on me that she was not dead. In fact, she looked really good, and she wasn't taking my medicine. I go, ma'am, I was so worried about you, and I thought you needed heart surgery, and you're doing so well, I don't understand. He goes, well, Dr. Roberts, you seem like a fine young man. I don't want to upset you, but when I went and I got chelation therapy. Huh? Chelation therapy, it doesn't work. Well, Dr. Roberts, you just said I was doing well. She was. She had gone to Dr. Chappell behind my back and got chelation therapy and got better. As it turns out, a handful of my patients were going down to Dr. Chappell and getting better, and they all kind of fessed up, and they told me about it. And gee, I was told by my professors that chelation didn't work. But all these patients with advanced heart disease are undergoing chelation, and they're getting better. So I called Dr. Chappell up, and I asked him, well, what are you doing? I was told that it didn't work. And he said, yeah, I was taught that it didn't work, but it does work. And well, how does it work? Well, we're dealing with lipid peroxidation. That was the term for oxidative stress. We feel that heavy metals are causing the generation of excessive free radicals and that our patients are deficient in vitamins and minerals. There's an imbalance with too much oxidative stress, oxidizing the LDL, and that was the driving force. So what we do, we use heavy metal detoxification to get rid of the metals, and we supplement them with vitamins and minerals. And that's what Dr. Chappell was doing 25 years ago. And Dr. Chappell was right, because look at this in the diabetic heart attack survivors who are on all of our standard drugs. If you give them chelation therapy and high dose vitamin minerals, they do well. Dr. Chappell, 25 to 30 years ago, understood cardiovascular disease better than any other cardiologist in the Midwest. So I have a great deal of admiration for Dr. Chappell, not just because he's smart, because he's a very, very, very strong man to take this position so long ago. Now, heavy metals are not the only cause of oxidative stress. We have smoking, organic pollutants, air pollution, other phenomenon, antioxidant detox genomic downregulations, overweight, diabetes, oxidative stress leads to endothelial dysfunction leads to oxidative stress. And we have inflammatory stress, we have some legitimate chronic infections like gingivitis, chronic urinary tract infections, that inflammation is leading to oxidative stress. Sleep apnea leads to a great deal of oxidative and inflammatory stress. So there's many causes of oxidative stress that we need to address, and we do. What are the endogenous sources of oxidative stress? Well, the key free radical is superoxide. All other free radicals are downstream from superoxide. How do we generate superoxide? Well, oxidative phosphorylation, NADPH oxidase, angiotensin converting enzyme, xanthine oxidase, uncoupled endothelial nitric oxide synthase, detoxification, and other enzyme systems. Now, 2% of the oxygen that we inhale is incompletely reduced to superoxide. We use oxygen to aerobically burn sugar and fat to make ATP energy. 98% of that of the oxygen is reduced to water. 2% is rendered oxidized as superoxide. So Mother Nature generates superoxide as a byproduct of energy generation. Now, when our body thinks that we have an infection, we're going to increase the generation of cholesterol because our white cells need cholesterol for their cell membranes. And our problem is that oxidative inflammatory stress due to modern living, overweight, leaky gut, high sugar diet, diabetes, toxicity, etc., is interpreted by Mother Nature as infection. So we're going to upregulate the expression of HMG reductase, which is the rate-limiting step in cholesterol generation. And our white cells need not just cholesterol to make cell membranes, they need bullets. They use superoxide to kill microbes. So in this process of generating cholesterol, we activate isoprenoid molecules that activate Rho kinase that puts NADP oxidase together. NADPH oxidase is our most powerful generator of superoxide. It's so powerful that in the resting situation, its components are kept apart. But when we think we have an infection or when we are responding to pseudo-infection due to oxidative stress, we upregulate HMG reductase, we make lipids, but we're also going to put NADP oxidase together and make free radicals, and we're going to use that to help our white cells become killing machines. And some of this superoxide will convert to hydrogen peroxide, and that will cause translocation of nuclear factor kappa beta, our most important inflammation amplification platform, to make more inflammatory cytokines. Oxidative stress leads to inflammatory stress leads to oxidative stress. Angiotensin converting enzyme converts angiotensin 1, a weak vasoconstrictor, into angiotensin 2, a powerful vasoconstrictor. So we use angiotensin converting enzyme inhibitors or ACE inhibitors to lower blood pressure. But most of the ACE is within our cells, and it upregulates tenfold in acute coronary disease. And ACE within the vascular wall leads to inflammation. Our mononuclear cells, our innate defenders, have a receptor for angiotensin II. With angiotensin II, nuclear factor kappa beta translocates to make more inflammatory mediators and cytokines and inflammatory and oxidative storm. So we want to block angiotensin converting enzyme in the vascular wall with fat-soluble ACE inhibitors that enter the vascular wall. If you have cardiovascular disease, even if your blood pressure is normal, and we block ACE within the vascular wall, we're going to help you out by lowering inflammation, oxidative stress in the vascular wall. Will decrease your likelihood of a future adverse event. Chelation therapy and antioxidants decrease your risk for an adverse event. So do ACE inhibitors. Why? They all lower oxidative stress in the vascular wall. Now, xanthine oxidase mediates the generation of uric acid and superoxide. So if you have gout from excess uric acid, we would treat you with allopurinol to block xanthine oxidase. Xanthine oxidase wastes oxygen, a precious molecule, and makes superoxide, a deleterious molecule. Xanthine oxidase is upregulated tenfold in coronary insufficiency, heart attack, and in heart failure. In this situation, the heart becomes a key generator of superoxide. So if you have these conditions, like all my patients, I know you're cranking out tons of superoxide in the vascular wall and in the heart, so I'm going to block that with allopurinol, and that will lower oxidative stress. You'll have less angina. This is good for your heart. It's good for your kidney. It's good in metabolic syndrome. Any condition that is associated with energy failure in the liver or the heart, you have an upregulation in xanthine oxidase, you're making too much superoxide. I block it, I lower oxidative stress, I will improve your outcome. Catecholamines, adrenalins. We break down adrenaline with an enzyme called catechol-O-methyltransferase. Its cofactors are magnesium and SAMe, S-adenosine. If we don't have enough magnesium, and most of us don't have enough magnesium, if we don't have SAMe because we're B vitamin deficient, and many of our patients are B vitamin deficient because of our diet, and the drugs that we give you, purple pills, PPIs, thiazide diuretics, many of them waste B vitamins. You don't make SAMe, you can't break down catecholamines, you have catecholamine excess. And then if you can't break down the catecholamines, they auto-oxidize and generate a great deal of hydrogen peroxide and superoxide. This is why beta blockers are helpful to the patient with cardiovascular disease. Superoxide will react with nitric oxide 3 times more rapidly than it will be neutralized by superoxide dismutase to make peroxynitrite. Peroxynitrite will degrade BH4, tetrahydrobiopterin, the key cofactor of nitric oxide synthase. Nitric oxide synthase in a reductive environment makes nitric oxide a good guy. It falls apart without BH4, and uncoupled endothelial nitric oxide synthase becomes a superoxide generator. If you're not part of the solution, you become part of the problem here, making superoxide. Now, Mother Nature gave us enzyme systems that generated superoxide, and as we'll discuss later, she gave us a vitamin mineral antioxidant defense system to neutralize this superoxide. The problem is that as modern man, we're being pummeled by non-intrinsic sources of superoxide: diabetes, visceral adiposity, smoking and airborne pollutants, heavy metals, and organic pollutants like 2,3,7,8 tetrachlorodibenzoedioxin. That is the contaminant that was in it that you know about from Agent Orange. So modern man is experiencing an overwhelming oxidative assault. Mother Nature did not design us for this. We're supposed to deal with the free radicals that primitive man would experience, and now we have that load and this toxic load and the load from our overweight, our leaky gut, our diabetes. We're getting clobbered, we're getting cardiovascular disease, we're getting kidney disease, we're getting diseases of aging, but at a younger and younger age. And thus we get out of balance, we have the oxidative bonfire. When I trained, we never saw women below the age of 70 or men below the age of 60 with heart disease. It didn't exist. Now we're seeing cardiovascular disease in 30-year-olds because we have a greater prevalence of oxidative stress. And we're having these oxidative bonfires at a younger and younger age. So oxidative stress means something is terribly wrong. So we need to measure oxidative stress, and I do this in every patient. Lipid peroxides would be akin to malondialdehyde or LDL oxidation. It means you don't have enough fat-soluble antioxidants to protect against oxidation of lipids in the vascular wall. And if I was just going to treat you with antioxidant support, I would choose fat-soluble antioxidants like vitamin A, beta-carotene, vitamin E, or coenzyme Q. 8-hydroxydeoxyguanosine refers to DNA that has been oxidatively damaged. And if you have high 8-hydroxydeoxyguanosine, I would use water-soluble antioxidants like lipoic acid or vitamin C. Glutathione is the middle linebacker of our antioxidant and detox defense systems. If you're low in glutathione, it's either due to genomic predisposition, which we now understand how to identify and treat, or you're burdened with free radical stress or toxins. Coenzyme Q is a fat-soluble antioxidant. Everybody in the United States now knows about coenzyme Q. So all of my patients are taking coenzyme Q when they see me, and they have good coenzyme Q levels. How did we learn about coenzyme Q? My colleague, Dr. Steven Sinatra, started talking about it 25 years ago, and I started talking to Steve, and my patients have been taking coenzyme Q for 20 years. But coenzyme Q alone, as you see, is not enough to deal with the overwhelming abundance of oxidative stress that our patients are generating. So what we want to do, we want to measure oxidative stress. We want to get rid of it. This man, I began working with him about 3 years ago. He had an autoimmune condition. He had recurrent coronary disease, a blocked artery, persistent angina despite medicines, and he was insulin insensitive. He would eat half of an apple. His blood sugar would rise from 80 to 400. So we began to work. We used drugs and non-drug and detox approaches, all of which lower oxidative stress. And he got a little bit better, and his markers have improved a little bit. He's still having angina, but not all the time. I saw him recently. He's doing better. He's actually angina-free for the first time. He's exercising, feels good, and now he can eat half an apple and his blood sugar doesn't go to 400. It goes up to like 180. His insulin insensitivity is improving. We're going to keep up our efforts. Eventually, he's going to be in the green zone. He's going to get better. The most important thing I can do with the patient is to resolve oxidative stress, because oxidative stress underlies everything else. If I just give you a drug for this, a drug for that, a third drug, and I don't deal with oxidative stress, I'm going to give you a fourth, fifth, or sixth drug. So we got to focus on oxidative stress, and metals are a key underlying cause that we must remove. Now, in allopathic preventative cardiology, that's standard orthodox cardiology, the drugs we use that work actually work by lowering the generation of free radicals. Statins downregulate NADPH oxidase, you lower superoxide. ACE inhibitors and angiotensin receptor blockers also downregulate NADPH oxidase, less superoxide. Beta blockers blunt catecholamine autooxidation, less superoxide. Allopurinol blocking xanthine oxidase directly blocks the generation of superoxide. Colchicine blocks the generation of interleukin-1 beta, less superoxide. Patoxylene blocks nuclear factor kappa beta translocation, less superoxide. These are the drugs I use, and the reason I use them is not just to lower your cholesterol, not just to lower your blood pressure, not to treat gout, but to lower oxidative stress. So we can use nutraceuticals, we can use detoxification, and in patients with advanced disease, when we're involved in secondary prevention, not primary prevention, we will use pharmaceutical approaches. Why not? So we're making superoxide. Mother Nature generates superoxide. She had to come up with a means of neutralizing, detoxifying superoxide, and that is superoxide dismutase that dismutates or neutralizes superoxide into hydrogen peroxide. We have SOD1, which is in the cytoplasm, the cell fluid, SOD2, which is in the mitochondria, our fuel cells, SOD3, which is on the vascular wall. The hydrogen peroxide will be converted to water and oxygen by catalase, glutathione peroxidase, and peroxyredoxants. This is Mother Nature's primary defense against free radicals. Now, some of the free radicals may break through, and thus we have our secondary defense, which are antioxidant vitamins and minerals, which we can obtain from diet or via supplementation. One problem, many of us are genomically downregulated in our ability to handle free radicals. And I routinely measure this in my patients, and most of my patients with cardiovascular disease harbor downregulations in our antioxidant defense molecules. And this was a good idea 1,000 years ago because we weren't dealing with toxins. We didn't have mercury fillings. We weren't exposed to lead or cadmium or aluminum, but we were fighting microbes. And if you were good at making free radicals and bad at neutralizing free radicals, you had more bullets to kill the microbes. So many of us, so this was adaptive for primitive man, it's maladaptive for modern man. So some of us who are particularly weak at neutralizing free radicals were the canaries in the coal mine. We get sick while the individuals who are genetically intact do not. We get sicker at a younger age in life. And you also need mineral cofactors. Superoxide dismutase to function adequately needs manganese and zinc and selenium. Glutathione peroxidase needs iodine. We tend to be low in minerals. I will check this in my patients. Those of you who are experiencing oxidative stress, you've depleted your manganese, your selenium, and zinc. Now, this is a big deal. If you look at the relationship between serum selenium and the number of vessels that are blocked, if you have high selenium, you're clear. As selenium levels fall, you have more vascular disease because you have weak antioxidant defenses. And our vitamin antioxidant defenses are interacting. Ascorbic acid, vitamin C, is our primary water-soluble antioxidant. Vitamin E is our primary intracellular fat-soluble antioxidant, and vitamin C will recycle vitamin E, and coenzyme Q and lipoic acid play a role here. So we have a teamwork, an interlocking vitamin-based antioxidant defense system to deal with any superoxide or hydrogen peroxide that breaks through our primary enzyme-based antioxidant defense barriers. There are many different sources of oxidative stress, and we need a team of antioxidants. So I liken this to a football team. What bothers me a lot is someone will come in and they're drinking this fruit juice from Southeast Asia that the Queen of England thought was a good idea, whatever, and it's all you need to do. And it's well and good. It's going to be rich in bioflavonoids, but we need a team of antioxidants. So you could take all the fruit juice you want, or you could take 1,000 milligrams a day of coenzyme Q. But if you're low in manganese, selenium, and zinc, the free radicals are going to break through. This would be like having a football team with several all-stars and a couple linemen with broken legs. The bad guys will find a way to break through. This is why we want to do nutritional testing. And this is why in the TACT study, we put you on a broad spectrum vitamin mineral program to cover all these bases. And this is very important because if superoxide and peroxide break through our defenses, myeloperoxidase will convert peroxide into hypochlorous acid, which is like bleach. And that's good to kill microbes, but you don't want to be bleaching your organs. Superoxide will react with nitric oxide to form peroxynitrate, which leads to endothelial dysfunction. The big problem is that heavy metals will catalyze the Fenton reaction that converts superoxide or peroxide into hydroxyl, which is 1,000 times more damaging than is superoxide. This is how heavy metals are bothering us. Any free radicals that break through, their toxicity is magnified 1,000-fold. So we're experiencing free radical overload. Superoxide generated by xanthine oxidase, angiotensin converting enzyme, NADPH oxidase. Superoxide needs to be neutralized by superoxide dismutase, catalase, and glutathione peroxidase. If not, we get peroxynitrite, hypochloric acid, or hydroxyl. And this is where metals are a problem. High iron and high copper will catalyze the Fenton reaction to make hydroxyl. This is why if your ferritin level is high, I will recommend that you give blood because excess iron acts just like lead and promotes oxidative stress. High ferritin increases cardiac risk. High LDL increases cardiac risk. High ferritin with high LDL synergizes to dramatically increase cardiac risk. And cadmium, lead, mercury, and aluminum are all promoting the conversion of superoxide and peroxide into damaging hydroxyl. We've got to get this stuff out of us. If not, we have oxidative stress. We go out of balance. We have inflammation. We have endothelial dysfunction. We have cardiovascular disease. Because oxidative stress is interpreted by our body as infection, so we're going to ramp up this process. We get hyperglycemia, hyperlipidemia, immune dysregulation, endothelial dysfunction, and cardiovascular disease. This response is appropriate to real infection, but it's inappropriate to a 50-year pseudo-infection where the body identifies oxidized LDL within the artery wall as a microbe. What are the mechanisms of metal toxicity? Well, oxidative stress, cofactor depletion, enzyme dysfunction, and there's a synergy between toxins. Multiple metals, interaction with organic pollutants. There was an animal model where you give an animal the LDL-10 of lead. That's enough lead to kill 10% of the animals. Then the LDL-10 of mercury, that's enough mercury to kill 10% of the animals. Then you give them the LDL-10 and the LDL of mercury, you get LDL-100, because different metals will compromise different steps in our metabolism. The more metals that we're exposed to, the more likely we are to have a problem. Plus, the metals will interact with organic pollutants as well. Now, metals destroy enzymes. They gum up the lock and they throw away the key. So enzymes participate in an assembly line process to generate new molecules. So the enzyme will grab a substrate and an energy source, such as ATP. It will catalyze the phosphorylation of the substrate to create ADP and a finished product that is then processed by another enzyme. The open active site of the enzyme will catalyze the next step, will catalyze another substrate. Well, if we have metals, they will bind to the sulfhydryl group in the active site of the enzyme, and like a key that doesn't fit in the lock, it just gets stuck and it kills the enzyme. The enzyme can no longer carry out its biochemical activities. It will be degraded. You make new enzyme, which is then poisoned by metals. So metals will gum up our enzyme system and compromise our biology. Mercury will inhibit methionine synthase, and thus you'll deplete your SAMe. If you don't have SAMe, S-adenosylmethionine, COMT, catechol-methyltransferase, cannot break down adrenaline. So those of you with mercury fillings or eating a lot of fish, over the years you're going to bring up mercury. You'll take in a lot of mercury. You can't break down adrenaline, so your blood pressure rises. All of a sudden you can't drink coffee, and you're stress intolerant because you're no longer able to break down adrenaline because of a mercury burden. Cobalt is quite toxic. It binds to sulfhydryl groups in lipoic acid and compromises our biology. So in World War II, cobalt was used in munitions, and the workers were grinding the cobalt, and they got a hypersensitivity pneumonitis, a pulmonary inflammation, leading to chronic lung disease, leading to cor pulmonale, which is right heart failure on the basis of cobalt. Cobalt is toxic to the bone marrow in such a fashion the bone marrow responds by cranking out more red cells. So cobalt was used to treat anemia. And this agent that was used was Roncovite. This was before my time, but they would give you Roncovite, and then they saw that it was causing hypothyroidism because the thyroid is a very energy-intense organ, and if you compromise the ability to generate energy from the cobalt, you get hypothyroid. Then we've got the problem with the cobalt beer cardiomyopathy. Now, if you drink a beer at a bar, you want to have foam on top. And the barkeeps would wash the used glasses with soap and water. They would dry, and then they would use them again. Well, then in the 1950s and 60s, industrial detergents came out, and they started using dishwashers, and it would leave a residue on the glass that would keep the foam from occurring. So you don't want to go to a bar and buy something like this. So the beer manufacturers began to put cobalt into the beer, and that would cause this artificial foaming. And then all of a sudden, we're beginning to see cobalt cardiomyopathy. Initial reports came out in Brussels, Quebec, and Nebraska. These were individuals who were big beer drinkers. Mostly they worked at the breweries, and they could just drink beer all day, and they drank an awful lot of beer, and they would develop a cardiomyopathy that was typically lethal. And what happens is cobalt binds to sulfhydryl groups in lipoic acid. Lipoic acid is necessary for vitamin C and coenzyme Q and vitamin D interact. And so sulfhydryl groups in lipoic acid, primary target of cobalt, so you're going to get a great deal of oxidative stress. Now, several enzymes involved in energy generation, pyruvate dehydrogenase and alpha-ketoglutarate dehydrogenase, these are the enzymes that are necessary to generate ATP energy as we burn sugar and fat, are compromised, so you can't generate energy. You have energy failure. This is what the heart would look like. These are mitochondria. They're supposed to be these small little organelles that are generating energy. They're swollen and dysfunctional, so they had a cobalt-induced cardiomyopathy. The orthopedic surgeons have been breaking bad with cobalt. Now, I knew about cobalt toxicity and lead toxicity and mercury toxicity when I was a senior in college. What happened was I was getting ready to apply to medical school. I had a really high GPA. I was Phi Beta Kappa and Phi Kappa Phi and chemistry honorary. But medical schools weren't interested in guys like me that had high GPAs. There was this call to have the well-rounded student. The idea being that if you were well-rounded, you might be a better doctor. That didn't turn out so well. The people with the high GPAs that work the hardest in college are going to be the best doctors because they're going to work the hardest. But anyways, I needed to look well-rounded, and I was anything but well-rounded. And I didn't have time to take a year off and go to Central America and help Indigenous people do whatever. So I needed to do something to look well-rounded. So I decided I would sign up for an art class. So I'm going to sign up for Art 40, Art History. And of course, the competition there, a bunch of freshmen, I could get an A and look well-rounded. Well, something went wrong with the school computer, maybe because I was a senior, and I wandered into Art 400, which is ceramics. And the competition then were juniors and seniors, art majors who wanted to get into a Master of Fine Art program. But this looked pretty cool. You know, it really looked like a lot of fun. Plus, I figured before the grades came out in December, I'd be in med school and it didn't really matter. So it soon became clear that I was not going to get an A in this class. Like, I wasn't any good at this. I was a lousy potter. And I began to sweat a little bit because I hadn't gotten to medical school by November. I had done an early admission at one school. I didn't get in, so I was waiting to go through the process with the other schools. And like, the grades are going to come out, and I'm not going to be in medical school, and this is going to be a bad thing. And the professor noticed my anxiety, took me aside, and he goes, Jim, you know, on a really good day, you'll get a C minus. You know, on a really good day. But I know you're worried about this, and I know if you get a C, you won't get into medical school, and I don't want to keep you out of medical school. I think it's kind of neat that someone like you, who's kind of a nerd, is learning pottery, so I'm going to give you a B. But don't tell anybody, because this is a gift. So anyways, I got a B. I still got into medical school. I took pottery for a year, and I actually got pretty good at pottery. Between residency and my fellowship, I had a year. And I stayed home and looked after our oldest, and my wife taught law school. And I got a potter's wheel, and I spent a lot of time doing pottery, and I had a lot of fun. Someday, I'm going to get back to it. But anyways, my senior in college, we would make glaze. And we would make different types of glaze. We would take little tiles and paint them with metals. Lead, mercury, cobalt would have different colors, and we would have different mixtures to get different colors. And we knew that this was toxic. So we wore gloves and a mask, so we knew that these metals were a bad idea. Well, the students that were going to go to dental school and the pre-med students that were going to become orthopedic surgeons didn't take this class. They didn't know that mercury was bad, and the orthopedic guys didn't know that cobalt was bad. And about 10 years ago, they started using metal on metal hips that contain cobalt. And if they didn't put the hip in just right, the hip components would grind and cobalt would leach out, and you would become totally overloaded with cobalt. And this is a total disaster. You have to take out the hip, and then we have to treat you for cobalt, but you are so cobalt overloaded and so sick. And we typically don't recognize this until you're really sick. It's a problem. I have 2 patients with cobalt hip cardiomyopathy and toxicity. One's doing okay, and the other is struggling. So we want to stay away from these metals, not just lead, not just cadmium, but all the metals, because they're not supposed to be in our body. Again, we grow our tobacco in Virginia and North Carolina because the soil is rich in cadmium. And this is looking at cause of death, heart disease versus non-heart disease in relation to your tissue burdens of lead and cadmium. So the people with high lead are dying of cardiovascular disease. The only people who die of cardiovascular disease that weren't high in lead were high in cadmium. Lead and cadmium synergize to produce cardiovascular disease. If you're high in lead and cadmium, you're more likely to die of heart disease than you are of another more benign cause. Now we got the problem of organic pollutants, dioxin, bisphenol A, phthalates, polychlorinated diphenyls, polychlorinated diphenylfurans, polychlorinated biphenyls. They have this ring structure, and that will become important in a minute because they mimic indoles, dietary components. They are lipophilic. They're fat soluble. They travel in your LDL. If we want to measure your burden of these, we measure it in your LDL. So this stuff is being transported into your artery wall by your LDL. They're all persistent to a variable degree. The body has trouble getting rid of them, and they're toxic. We can call them POPs, persistent organic pollutants, or PLOPs, persistent lipophilic organic pollutants. Mechanism of toxicity, metals, enzyme dysfunction, cofactor depletion. Metals can bind receptors. We'll talk about this a little bit later. Cadmium binds the estrogen receptor more tightly than does estrogen. It's responsible, at least in part, for the epidemic nature of breast cancer and prostate cancer. Oxidative stress, endothelial dysfunction, and there's a genomic predisposition. If you have trouble with detoxification, the metals are going to bother you more than the next person. Organic pollutants are endocrine receptor disruption. They gum up the testosterone and the estradiol receptors. Menarche is occurring 3 years earlier today than it did in 1900. Baby boys are being born with defective external genitalia. These organic pollutants are readily transported across the placenta. Our bodies are concentrating these, and the concentration rises from generation to generation to generation. If we don't do something about this, we're going to have a children of men situation with infertility, and all the kids will be born with important challenges. Also, there's pathological ligation of the aryl hydrocarbon receptor. The aryl hydrocarbon receptor is sampling the environment in the GI tract, and when it's activated, when it's ligated, you increase detoxification, phase 1 detoxification. So these toxins initiate phase 1 of their detoxification, which generates free radicals, but they're not subject to phase 2 detoxification where they're taken out of the body. So they sort of sit there and cause oxidative stress pretty much for the rest of your life. If you served in Vietnam and you were exposed to Agent Orange, the TCDD, the dioxin, is still in your body. You can't get rid of it. It's still causing oxidative stress, and it's still harming you. Persistent oxidative stress is the problem. The aryl hydrocarbon receptor is upregulated in coronary disease. We're going to take 1,800 Han Chinese, ethnic Chinese, 939 with coronary disease, 868 controls. Those with coronary disease have a greater burden of risk factors than the controls, as you would expect. And they have a greater expression of the aryl hydrocarbon receptor in their white cells. So if you look at peripheral mononuclear cells, monocytes and macrophages, they are generating they're reading their DNA and making messenger RNA for their hydrocarbon receptor. The patient with coronary disease more so than the controls. As you go from controls, stable angina, unstable angina, non-ST segment elevation myocardial infarction, full thickness, ST elevation myocardial infarction, you see greater expression of their hydrocarbon receptor. We don't know why, if it's genetic, but it's probable that the greater the degree of lipophilic toxicity, the greater the degree of upregulation of the aryl hydrocarbon receptor, the more you're taking this stuff into the artery wall, the more oxidative stress you're generating. Of course, the greater your risk of cardiovascular disease. So we have metals, which is the subject of this presentation, and we have organic pollutants, and we have another extensive presentation on how to measure and how to get rid of organic pollutants. So organic pollutants can cause endocrine disruption. They gum up the testosterone and the estradiol and the thyroid receptors, pathological ligation of the aryl hydrocarbon receptor, fetal detoxification, oxidative stress, and they synergize with hydrophilic metals. Now, the organic pollutants are fat soluble. The metals are water soluble. They're hydrophilic, water loving. Harold Zeliger is a toxicologist, very smart guy, and he's worth reading. He feels that there's a synergy between metals and organic pollutants. He feels that organic pollutants kind of create pores in the cell membrane to allow the metals in. And these organic pollutants, some of them are persistent. Dioxin and PCBs will persist for decades. Again, if you were exposed to TCD in Vietnam, Agent Orange, it's still in you. Some are shorter lived but ubiquitous. Phthalates and aromatic hydrocarbons, air pollution. This is what we get when we drink from plastic water bottles. Some are rapidly clear, but they're taken daily. Statins, antidepressants, and antipsychotics. There's a role for statins. We will use them to downregulate HMG reductase and downregulate NADPH oxidase, lower LDL, lower oxidative stress. They have a role. But when you take a statin, your blood sugar will rise. It'll rise 5 to 10 points. Why is it doing that? If you take antidepressants or antipsychotics, you may gain weight. Why is this happening? And Zellweger thinks that they're creating rents in the cell membrane, allowing other toxins in to compromise your biology, thus the high sugar and the weight gain. And concomitant exposure is not necessary. He published all these case reports of people that were exposed to organic pollutants at one time point, and then later on they get exposed to metals, not at a really high level, but then they get really sick. And he feels that because these organic pollutants are persistent, they're making these rents in the cell membrane, making you more susceptible to metals. In any event, we want to get rid of the metals. We want to get rid of the lipophilic organic pollutants. We want to deal with oxidative stress. Let's talk a little bit about lead. We get lead from paint, auto exhaust, water, tobacco, industrial waste, and ceramics. Now, we took it out of gasoline, but as you'll see, that lead is still in us, because once it's in us, it just doesn't come out. It's a one-way street. Lead inactivates enzyme systems, displaces nutritional metals, degrades nitric oxide, endothelial dysfunction, free radical stress. Now, in children, they will absorb it more readily from their GI tract. 25 to 40% of the lead that a kid ingests will be absorbed versus 5 to 10% in adults. The developing nervous system takes it in, neurodevelopmental disease. We're all aware of this when the problem in Flint. Now, we used to say that the safe or acceptable level of lead in kids was 40. With subsequent research, we took it down to 10. And now we would say that 10 is enough, that 10 is safe. In adults, 95% is stored in bone, and our bone lead level is now 100 times greater than it was 100 years ago. And lead is associated with hypertension, cardiovascular disease, and kidney disease. Cardiovascular risk of, quote, normal blood lead levels, as if there's anything really normal about having these toxins. Primitive man didn't have any of these toxins. Saying there's a normal level is sort of an excuse to say we don't have to do anything about it. We do not have to be responsible stewards of our body. Now, a blood lead level above 10 is associated with an increased risk of neurologic disease in kids. Everybody would admit to this. Blood level less than 10 in kids is considered normal. Don't worry about it. But kids with a level of 10 have an IQ 7.5 points below kids with a level of 0 to 1. 7.5 IQ points is huge. That's the difference between a job that requires cognitive function, where you're going to contribute to society like a butcher, a baker, a candlestick maker, and a job that does not require cognitive integrity, where you're not going to be contributing to society, such as being like a Medicare administrator. And of course, I gave this talk to doctors, so everybody got a chuckle out of that one. Now, a blood level of above 10 is associated with an increased cardiovascular risk in adults. 99% of U.S. adults now have blood levels below 10 because we took it out of gas and out of tin cans. But if kids are not okay with a level below 10, is there an increased cardiovascular risk in adults at a lead level below 10, between 1 and 10? So what we're going to do here, we're going to take just over 1,400 adult participants in the third NHANES study. This is the National Health and Nutrition Education Survey. Record at baseline your standard cardiovascular risk factors and blood lead. You're going to exclude the minority of the patients, 707, with blood levels above 10. And we're going to look at just below 1,400 who had quote unquote normal levels. The mean level was 2.58. The first tercile, the lower third, was 0 to 1.9. The middle tercile was 1.9 to 3.6. The third tercile was anything above 3.6. We're going to record mortality and cause of mortality over the following 12 years. does a quote unquote normal range lead affect long-term mortality. Now, if we look at all-cause mortality relative risk, being in the middle tercile did not increase your risk, but if you were in the upper third, you were 30% more likely to die over the follow-up period. If you were in the middle tercile, your cardiovascular death risk rose 6%, but if you were in the third tercile, above 3.6, you rose 64%. Death due to myocardial infarction, 5% or 100% risk. You were twice as likely to die of myocardial infarction if you're in the third tercile. Stroke mortality, and stroke is linked more to high blood pressure than with heart attack, and lead causes high blood pressure. It's a cause of high blood pressure. If you're in the middle tercile versus the third, you're 2.2 times as likely. In the third tercile, you're 2.6 times as likely to die of stroke as individuals with lower lead levels. And why is this occurring? Because lead causes oxidative stress. If we look at your relative risk for a future event, if you're in the second or third tercile for LDL versus the third, your risk rises. But if it's oxidized LDL, your risk skyrockets. Lead leads to oxidative stress, leads to cardiovascular disease, leads to hypertension, increased risk of heart attack and stroke mortality. That makes sense. Lead and hypertension in men. What is the mechanism? 33 men aged 28 to 58, 25 were exposed to lead for weeks to months. They were welders, they were metal cutters, and they would monitor lead blood levels in the workplace, and if their lead level got high, they were taken away from the workplace and they were returned when their blood lead level returned to normal, which is a big mistake because it's not being excreted from the body, it's entering your cells. So if you take them off work for a month, their blood levels normal, that's because it's all in their cells. That was a bad idea. But anyways, that was their practice. And then you look at 8 non-exposed workers. We're going to measure labs pertaining to the renin, angiotensin, aldosterone system, the RAAS. Now, what you see here, you can see this is a very old study because we had to photocopy the graph. Lead correlates exponentially with renin. Renin is released by the kidney and leads to the generation of angiotensin 1. The kidney will release renin in response to oxidative stress or impaired blood flow. Lead causes oxidative stress, vasoconstriction. The kidney releases renin. Then angiotensin 1 correlates linearly with renin and exponentially with lead. ACE, angiotensin converting enzyme, correlates linearly with angiotensin 1 and exponentially with lead. Aldosterone, this is a hormone released by the adrenal that retains sodium and water and wastes potassium and magnesium, correlates linearly with lead. So lead led to activation of the renin, angiotensin, aldosterone system. You're making more aldosterone, you're making more angiotensin 2. That causes oxidative stress, vasoconstriction, salt and water retention, and hypertension. So lead is linked with hypertension in men. Adult blood lead levels have dropped by 90% over the past 20 years. But that doesn't mean that it's out of our body. It's locked into our cells. 95% of our lead is in bone. Once it's in, it's pretty much locked in forever. The Normal Aging study looked at bone lead, which is an index of body burden, and it rises steadily with age in men. As your bone lead, your body burden of lead rises from 8 to 37. The first to fifth quintiles, your risk for hypertension rises by 50%. In women, the relationship is more important and more complex. As you go from the first to the fourth quartile for lead, in premenopausal women, your relative risk for hypertension rises. In postmenopausal women, the relationship is even stronger. Why? With bone loss, with menopause, old lead and cadmium comes rushing out into your circulation. So that's one of the reasons your blood pressure rises with menopause. When seniors fall and break a bone, they tend to fall apart. When you break your hip, you fall apart. And we go, well, gee, that's because they're going to be infirm for a period of time. And indeed, that's the case. But it also may be that when you break a big bone, a bunch of lead and cadmium and other metals rush out to compromise your biology. Serum creatinine rises as a sign of kidney dysfunction, and it rises in relation to blood lead. Creatinine tends to rise with age as a result of of an age-related decline in kidney function, which is not pathologic, but if you're in the fourth quartile for lead, it rises more rapidly and severely than if you have a lower lead burden, because lead is toxic to the kidney. Let's talk about cadmium. Again, we get cadmium from smoking tobacco, nickel cadmium batteries, welding and zinc smelting, metal coatings, foodstuff, shellfish. It was in lung fungicides until 97. Golfers would get sick from cadmium, and your mother. It readily traverses the placenta. So if your mom smoked, you were born with a huge cadmium burden, and the half-life is 20 years. That means if you have a given burden of cadmium and you stop taking in cadmium for your cadmium level to fall by 50%, it'll take 20 years. So once it's there pretty much forever. Cadmium and hypertension. I have a number of patients in my practice that live in Kansas City, and that's because Caroline Reiser practiced in Kansas City. Caroline Reiser was the best Lyme and chronic infection doctor in the United States. She's retired recently, but she would send me patients, and they'd be sitting in the waiting room interacting with my Toledo patients, and inevitably they'd have a conversation, and the Toledo patient would say, you know, I like Dr. Roberts. I like the way he practices medicine. That's why I'm here. But like, you live in Kansas City. You've got cardiologists in Kansas City? And the guy from Kansas City would say, well, cardiologists in Kansas City, with my case, they've gone about as far as they could go. And the city fathers of Kansas City have gone about as far as they can go to increase the business activity of the cardiovascular community. Hard water is usually protective against hypertension, cardiovascular disease, but not in Kansas City, Kansas. Kansas City, Kansas, Kansas City, Missouri draw their water from the same source, but in Kansas City, Kansas, the water is twice as hard as the softened water in Kansas City, Missouri, but they did something wrong in Kansas City, Kansas. They introduced cadmium to their water, and their serum cadmium level is tenfold greater in Kansas City, Kansas than is Kansas City, Missouri, so they have high blood pressure, more heart disease. Great place to practice cardiology, by the way. So let's look at cadmium and risk of myocardial infarction, heart attack. Just under 5,000 adult participants in the third and Haynes study recorded baseline your standard risk factors: urine cadmium, not bone cadmium, not provoked cadmium, but urine cadmium, because this was an easy assessment to make. And in this large national study, they needed to do easy assessments. Presence of prior infarction, that's heart attack. They divide the urine cadmium into the first, middle, and third terciles. Nothing here was considered pathologic. This is the normal levels of cadmium in the population. Correlate cadmium burden with risk factor adjusted myocardial infarction risk. Does cadmium increase risk for heart attack? And of course it does. Now, we get most of our cadmium from smoking. And if you look at men and women, never smokers, former smokers, current smokers, cadmium will rise. So the former smokers have a cadmium burden that's not going to go away for 20 years, and the current smokers have an old cadmium burden, and each time they smoke, they're introducing more cadmium. So of course they would have higher levels. Relative risk for heart attack, and you adjust for all the other risk factors. For men in the second tercile, you rise 9%. In the third tercile, you rise 26%. Women appear to be more sensitive to cardiovascular disease on the basis of cadmium. Second tercile, you rise by 27%. Third tercile, you rise by 80%. Serum cadmium levels are higher in hypertensives versus people with normal blood pressure, people with cardiomyopathy. Cadmium binds the estrogen receptor more tightly than does estradiol. This is an animal study where you remove the ovaries from an animal so they have no estrogen, and you treat them with estradiol, and you can see mammary gland development, so breast development, uterine development, and you can block that with an anti-estrogen. If you give them cadmium, you get the same effect that you can block with an anti-estrogen, because cadmium binds the estrogen receptor and has an estrogenic effect far more tightly than does estradiol. The epidemic nature of breast cancer and prostate cancer, because they share a common physiology, a lot of that has to do with cadmium. I see cadmium in my patients. This was a study carried out in Italy. They did endomyocardial biopsies. What you do, you put a catheter into the right heart with a little fingernail clipper thingy on it, and you grab a little chunk of heart muscle and you pull it out. I did a lot of these when I trained because they were doing heart transplants at the University of Cincinnati, and it's an awful lot of fun to do these biopsies. And you have to do it just right. You have to have the catheter against the interventricular septum. If it's against the free wall of the right ventricle, then you'd poke a hole in the heart and they would bleed. And that was a bad thing. So we were always very careful to do the biopsy correctly. And I think you're all glad that I'm trying to prevent the need for cardiomyopathy rather than doing heart muscle biopsies on you. But in any event, they did heart muscle biopsies on people with dilated cardiomyopathy. That is a weak heart muscle, poor ejection fraction. We don't know why. And these patients had 22,000 times as much mercury in their heart than did normal people. That doesn't mean they were exposed to 22,000 times as much mercury as others. Maybe they had a genetic predisposition, something like that, but it shows that cardiomyopathy mercury is associated with cardiomyopathy, and the higher the mercury levels, the worse was their ejection fraction, the more complicated were their arrhythmias. So mercury's playing a role here. So EDTA Chelation, how does it work? We give you this molecule, it binds a metal, you take it out through the kidney, you take it out through the liver. What steps in atherosclerosis are attenuated? Well, we're probably lowering cholesterol, we're probably blocking endothelial dysfunction and vascular wall permeability. We're probably blocking phospholipases that will cause the lipids to clump together, and we're really blocking oxidative stress. So the trapped lipids are less likely to be oxidized. You're not going to have this intense immune system dysregulation. Optimal concomitant therapies, well, metals aren't the only cause of heart disease. Metals aren't the only cause of oxidative stress. We use drugs, we use nutritionals to block other steps, other phenomena that cause oxidative stress. And we talk about that in different presentations. The next question is, if this is so important in the heart, will metal detox and oxidative stress reduction benefit other organ systems such as the kidney? Now, when you think about the kidney is one huge vascular surface that is filtering the blood, reabsorbing what should be reabsorbed, and excreting in the urine wastes and toxins. So it is logical to assume that anything that is bad or good for the arteries is bad or good for the kidneys. And renal dysfunction, kidney insufficiency, and atherosclerosis are both driven by enzyme dysfunction, oxidative stress, endothelial dysfunction, and the same skewed, dysregulated immune response. So will chelation therapy help in kidney disease as it does in chronic coronary disease? We're going to take just over 202 patients with chronic non-diabetic renal insufficiency. 50% had chronic glomerulonephritis. That is an autoimmune condition where the immune system attacks the kidneys and the kidneys fail. 11% have nephrosclerosis, the consequence of childhood urinary tract infection. 12 had analgesic induced, too much ibuprofen to damage the kidney. 7 had polycystic kidney disease, which is a genetic abnormality. 5 had obstructive disease, kidney stones, or a kink in the ureter. The urine dammed up and damaged the kidney. 15% unknown cause. 9% are smokers, 46% have high cholesterol. Over half were hypertensive, and you put them on ACE inhibitors, which lowers blood pressure and lowers oxidative stress. ACE inhibitors are cardiac protective, they're vascular protective, and they're kidney protective because the kidney is damaged by oxidative stress. Their creatinine was between 1.5 and 4.0. The creatinine is generated in your muscles, it's released into the circulation, it's filtered through the kidney. Your muscle mass is constant, so if your creatinine is going up and down, that would reflect changes in kidney function. The normal creatinine is about 1.2. If you're 5 or 6 or 7, you might be on dialysis. These people all had moderate kidney disease with creatinines between 1.5 and 4. They've been stable for 6 months. Their glomerular filtration rate, GFR, on average was 32. Normal is 100, disease is 60, dialysis is like 10 to 15. So these patients had moderate chronic kidney disease. They were felt to have a high normal total body lead burden. They were not painters or welders, no history of occupational lead exposure. And what they did, they treated them with 1,000 milligrams of EDTA and collected urine for 3 days and measured how much lead came out. And their lead spill was between 80 and 600 micrograms. Above 600 micrograms, they said they're lead toxic. Below 80, they said they are so clean and pristine, they don't want you in the study. They felt that 80 to 600 was kind of like the normal expected lead burden in an industrial society. This was carried out in Taipei, an industrial city similar to Detroit, Toledo, Chicago, Columbus, etc. So you're going to establish the natural history, measure creatinine every 3 months over 2 years. At 2 years, randomized 64 of the subjects to a 3-month treatment protocol. Control group got weekly placebo, sugar water, dextrose in their IVs. The chelation group received 1,000 milligrams of EDTA intravenously every week, and then they would collect urine for 3 days, and they kept this up until they had cleaned the lead out of the soft tissues, until the post-treatment urine lead was below 60. Now, 95% of the lead is in bone, where it doesn't bother you. But the lead in your soft tissues, your kidney, your heart, your liver, your vessels, that's what's damaging you because that's where your biochemistry is being carried out. So the best measure of lead in your soft tissues is a post-provocative challenge. So they gave the subjects EDTA. They would look at what came out in the urine. When they got down to 60, they said, at least for now, we've cleaned it out. And then you measure the creatinine every 3 months over the next 2 years, and maintenance chelation was provided. The control group got placebo IVs for over 5 weeks every 6 months. The EDTA group, once they cleaned them out, got the lead below 60, they would do a challenge every 6 months, and if their post-EDTA urine lead was above 60, they would treat them until they clean them out again, because what will happen is we'll clean out the lead from your soft tissue, and that will create a gradient between deep tissue stores like bone and your soft tissue, and that will encourage the egress of lead from bone back to soft tissue, recontaminating you. They realized this, thus they had maintenance chelation to maintain the gain, to clean the lead out of the soft tissues. Concomitant medical theory is the same. Quantifying renal function is the rate of decrease in GFR. Assess treatment-associated cost. Will EDTA chelation preserve kidney function? Well, what they found was blood level fell from 6.1 to 3.9. That's not incredibly impressive, but the soft tissue body burden, what you could pull out of the soft tissues, fell a lot more, from 150 to 43 micrograms with chelation therapy. Now, so the chelation group received just over 5 grams of EDTA. The range was 4 to 12 grams over the first 3 months. Now, this is the observation period. Both groups were observed over 2 years, and you can see a steady decrease in the GFR. As a general rule, if you have kidney disease, we expect it to slowly worsen, and eventually the nephrologist will intervene with dialysis. So in the control group, they continue to go downhill. Their GFR continued to fall over the 3-month intervention. But over the 3 months of chelation, you can see the EDTA group, they didn't go downhill, they got better. Renal function improved with just 3 months of chelation therapy. Their GFR rose. What about long-term? Well, long-term, the control patients continue to go downhill, headed towards dialysis. The chelation group improved and they were maintained. And if they had gone on further, maybe they would be maintained forever. We don't know because they stopped the study at this time point. They estimated that EDTA treatment would delay dialysis by 3 years. The cost of chelation is $3,750, labs, IVs, clinic visits, paying the staff. Cost of 3 years of hemodialysis is $61,000 per patient per year, over 3 years. EDTA chelation can and will improve kidney function and will save Medicare and the insurance industry billions and billions of dollars. Now, another study in diabetics. Same experimental protocol, both groups are going downhill, and then you intervene for just a few months, and you can see that the rate of decline in GFR is blunted with a few months of dialysis. The control group's going downhill, the chelation group improves. Now, in this study, there was no maintenance therapy. Big mistake. So they didn't do as well as the first study, but still, the chelation patients, while they still went downhill, they went downhill at a lower rate because the brief chelation they received had lowered their lead burden and lowered their degree of oxidative stress. Another study, non-diabetic kidney disease, over 4 years with maintenance, you can see everyone's going downhill, the chelation group improves, and they They don't stay where they are, but they don't decline very rapidly. Doubling of baseline serum creatinine, 27% of the placebo group, only 5% of the EDTA group. So we have 3 big studies published in major journals such as the New England Journal of Medicine, that are supposed to be read by all doctors, showing that chelation therapy works in chronic kidney disease, just as in the TACT study we showed that it works in chronic kidney disease. Let's look at lead and kidney function. 269 Spaniards, none with occupational lead exposure, none with clinical or laboratory diagnosis of lead overload. We're going to look at healthy controls. Their creatinine clearance was 108. Normal is 100. Individuals with quote-unquote essential hypertension, you have high blood pressure, and we don't tell you why, and as you are now coming to suspect, that's because you have a metal burden. They have essential hypertension, their kidney function still maintained. Hypertensive kidney disease, you got high blood pressure, your creatinine clearance is down to 47. Hypertension and gout and chronic renal insufficiency, creatinine clearance is 41. This is saturnine gout. Moonshiners will develop hypertension, kidney disease, and gout because they would ferment their corn whiskey in vats lined with lead. They would drink it. They become lead toxic. They would get high blood pressure. They would get kidney disease. They would get gout. So this group, you would expect a lower creatinine clearance. Then chronic renal insufficiency with a known etiology, a known cause, their creatinine clearance was impaired, and we know why. They had glomerulonephritis, autoimmune disease, polycystic kidney disease. Chronic pyelonephritis is chronic infection. These were younger patients. The hypertensives and those with and without cardiovascular disease or without kidney disease were older. These were younger people, and the younger you are, the less time on the planet you have to accumulate metals. These folks would have a lower toxic burden. You're going to measure blood and urine lead, and urine lead over 72 hours following 1,000 milligrams of EDTA. Above 600 was considered a high lead burden. Below 600 was considered a normal or expected lead burden. So blood lead levels in the healthy controls was similar to that of the younger people with chronic kidney disease of a known etiology. But if we look at blood lead, it rises. High blood pressure with renal insufficiency, high blood pressure with renal insufficiency and gout, that would make sense. The non-provoked urine lead was pretty much the same in the controls and the hypertensives. It was lower in the chronic renal insufficiency with known etiology because they were younger people. The younger you are, the less lead you're going to accumulate. You're going to have lower levels in the blood and in the urine. But a non-provoked urine lead level really is reflecting the lead in your blood that day. What is entering from your cells or what you're getting in from diet and water. So the non-provoked lead was not telling, but the post-EDTA provoked lead level, which is what is in your soft tissues, what is in your kidney right now, you go from controls, hypertension, hypertension with renal involvement, hypertension with renal involvement in gout. You can see they have much more lead in their soft tissues and their kidney, suggesting that lead is a key player in their kidney dysfunction. Bone lead, which is total body burden, was greater in those with a high post-EDTA spill than in the controls. So a high spill after EDTA is not just soft tissue, but body burden and bone. Delta ALA is an enzyme that is activated specifically in response to lead overload. It's a biomarker of lead overload. It was also greater in those that had a high spill. So the blood level doesn't mean a lot. The unprovoked urine level doesn't mean a lot, but a high provoked urine level means a lot. It means you have a soft tissue burden. It means your biology is compromised. It means your total body burden is increased. So a high lead burden is not common in healthy controls. Chronic renal insufficiency of known etiology, younger subjects. A high lead burden is seen in 15% of the hypertensives, 44% of those with hypertension and renal involvement, 68% of those with renal insufficiency, hypertension, and gout. A high lead burden correlates with increasing creatinine, elevated delta ALA, elevated bone lead. Blood lead level is not helpful in diagnosis. Use a provocative challenge. I never measure blood lead levels. They're worthless. It's a dumb idea. If a patient comes to me and they have this blood lead level that their doctor did and said, gee, you're not lead toxic, I immediately come to an understanding that that doctor does not understand heavy metal overload. We have to do a provocative challenge to measure what is in your soft tissues. Chronic renal insufficiency itself is not the cause of an elevated lead burden. Lead is etiologic. It's causative in a large percentage of patients with chronic renal insufficiency. Lead chelation is of universal value in chronic renal insufficiency. Someday, the FDA will approve chelation therapy in chronic kidney disease and in chronic cardiovascular disease, and then Medicare and insurance companies will start paying for it. We're going to put chelation therapy in the hands of primary care doctors. We will dramatically decrease our hypertensive burden, the need for dialysis, and the need for cardiovascular interventions. But I'm doing this right now. 64-year-old man with hypertension and kidney dysfunction. His blood pressure was normal on lisinopril, an ACE inhibitor, and hydrochlorothiazide, a diuretic. His creatinine's elevated at 1.5, and normal is like 1.1 to 1.2. His renal ultrasound was normal. He did not have obstructive kidney disease from a kidney stone or enlarged prostate. We do a provocative challenge. We give him EDTA, DMSA, and DMPS, and I see a lead burden. I don't see mercury, I see lead, so I'm going to treat him with EDTA, our most powerful lead detoxifier. So we treat him, he gets 20 treatments, and we get him off the drugs, his blood pressure normalizes, his post-provocative challenge, lead spill falls. Just like in the study, we cleaned out the soft tissue, his kidneys got better, and his blood pressure got better, and we can do this all the time. Now, if a patient does not have a lead burden or a cadmium burden, then chelation won't help, but just about everybody does. And to find out, we do a provocative challenge, and if we see the metals, we will clean them out. Heavy metals, lead, cadmium, mercury, arsenic, nickel, and aluminum are not normally present in the human body. No beneficial role in human physiology. They're pure toxins. There's no normal level. It's just that some of us aren't yet sick from metals. You know, a healthy American is someone who hasn't yet been diagnosed with autoimmune disease, heart disease, or cancer. The metals are ubiquitous in the environment of modern man. It's a new development. Mother Nature provides us with no defense against them. Mechanisms of toxicity, oxidative stress, endothelial dysfunction, displaced nutritional metals, inactivates enzyme systems. So how do we treat metal-induced pathophysiology? We'll limit ongoing exposure. If you smoke, stop smoking. If you got mercury fillings, we got to get rid of these things. If you have high ferritin, which acts physiologically like lead and cadmium and mercury, you give blood to the Red Cross. That's good for society. There's nothing wrong with your blood, but you don't want that iron. So if you give blood, your bone marrow will have to make new red cells, and you'll use up your iron, and you'll lower your iron stores. Change your personal environment. Do your very best to limit toxins. Now, I know you can't all go live in the woods in a hut, but do your best to change your personal environment. Some of you who I don't like a whole lot, I wish you would go off to the woods and live in a hut, but the rest of you, my patients and friends, I want you to stick around. Evaluate the level of oxidative stress. Look at your antioxidant defenses. We can do nutritional testing, genomic testing, look at our detox defenses, and assess your toxic burden. How do we do that? Some practitioners use hair analysis, but that's what the body can excrete. And many people are so toxic you cannot excrete it in the hair. And I think it's also heavily weighted towards recent exposure, not body burden. I don't think it correlates with what's in your bone. Standard laboratory is not helpful. Blood lead is recent exposure. Urine lead is recent exposure more than cellular burden. Red blood cell lead is 2 to 3 month exposure, kind of like a hemoglobin A1C. It's a useful guide, but if I don't see it in your red cells, that doesn't mean it's not in your kidneys and your liver and in your arteries and your heart. Organ biopsy would be great. If I could biopsy your liver, I would know, but lead concentrates variably in our internal organs, and most of it is in bone, so we would have to do a bone biopsy, which we're not going to do. Provoked urine metal levels is the best indicator of soft tissue intracellular metal burden, and then physician training, judgment, experience is important. I've been doing this for 20 years. I probably have a more extensive experience in chelation therapy than does any other cardiologist in the United States, and that's because I'm older and I have gray hair, and I participate in the training of cardiologists, non-cardiologists in chelation, and I'm involved in the chelation therapy research. So how do we carry out this urine-provoked metal assessment? We administer to you a panel of chelators. We have you take an enteric-coated phosphatidylcholine EDTA before and after. This blocks enterohepatic recirculation. we're going to give you the chelator, and most of it's going to bind the metals and take it out through the kidney. Some goes through the liver into the gut, and the bond between the EDTA and the toxin may break, and it'll reabsorb in your circulation. If we have a chelator in your gut, we'll bind up the toxin to go out in the stool. So you take an oral EDTA preparation, DMSA, and oral chelator that is specific for lead and cadmium, IV EDTA, which gets lead stronger than any of the other chelators, DMPS, which is more specific for mercury. You get this committee of chelators. We do a 6-hour urine heavy metal assessment, and I see what your predominant burden is. Now, this patient had high cadmium and high lead and some aluminum. This man worked in a radiator factory. He had the highest level of lead I ever saw. This was a physician who died of bone marrow failure. Later on, he had bismuth and antimony. We had no idea where that antimony came from, but he had high antimony. And now, of course, we're looking at cobalt. With the cobalt hips, we're finding patients with cobalt toxicity. What are the factors affecting the challenge results? The soft tissue content of a given metal, the number of different metals, the binding avidity of the chelators administered. If I gave you only EDTA, I would see lead and cadmium, I would see no mercury. If I gave you only DMPS, I would see mercury, I would not see cadmium. So I'm going to give you this panel of chelators, and then I kind of get a broad spectrum look at what is in you. If you undergo challenges in different practices, and the doctor uses a different combination of chelators, that would not be an apples-to-apples comparison. An apples-to-apples comparison would be repeat challenge with the same protocol, and we'll treat you for a period of time. We'll repeat the challenge to see where we are, and based upon the results, I might switch to a different chelator. I might go from EDTA to DMPS or vice versa. Integrity of the detox routes. If your liver and kidney are not functioning normally, less comes out. So we're going to pay attention to liver and kidney function, and we'll do our best to support those detoxification organs. There's no standard cutoff. You know, we have cutoffs for high blood pressure, high cholesterol, for your hemoglobin. There's no such thing for metals because we all vary in the number of metals we have, the integrity of our detox routes, and we also need to understand there's no normal levels of metals. So this tells me where I want to focus my attention, but I want to get rid of your metals. And the sicker you are, the more I need to get rid of the metals. So we evaluate your toxic burden and we treat you. If you're experiencing oxidative stress, I'm going to give you antioxidants. Detox defense support. We're going to be thinking about the kidney, liver, and the GI tract specific supplements. Now we have, to get rid of organic pollutants, we have phase 1, phase 2 detox predominantly in our liver. Phase 1 activates a fat-soluble toxin. Phase 2 binds a chaperone such as glutathione, glycine, or taurine to get it out of the body. We want to support this in all of our patients. We want to support detoxification. NRF2 is nuclear erythroid factor 2, a horrible long name. When it senses oxidative stress or toxicity, it enters the nucleus and transcribes antioxidant and detox molecules like glutathione S transferase. We give you NRF2 translocators like sulforaphane, which is like broccoli extract. It's not a toxin, but it looks to the body like a toxin, and you're going to upregulate generation of all of your antioxidant and detox molecules. Metallothionein, its job in health is to store zinc, but it will also bind cadmium and lead and assist the body in detoxification. It might be our only endogenous metal detoxification system. There's supplements you can take so you can make more metallothionein. So we'll have you take these supplements to make you better able to handle the toxins that you are being exposed to from the environment. This makes an awful lot of sense. Primitive man didn't need this, but modern man does. And then chelation therapy specific to the individual metal burden. Now, if the problem is lead and cadmium, I'm going to use EDTA. A hexadentate chelator is like a claw with one active site. It will bind lead and cadmium and take it out through the kidneys and out through the liver, and it doesn't stick around. All it does is redistribute metals and binds toxic metals and takes them out. If the problem is mercury and lead, or if you don't want to receive a IV chelator, I might use DMSA. This has been around for 40 to 50 years. This is what you use to treat kids that are lead toxic. It's a weak chelator of mercury and lead. It does not enter cells, but it will enter the nervous system. You can take it orally. It does not enter saliva. It won't pull mercury out of your fillings, but it will remove mercury from your body. DMPS is my favorite mercury chelator. 2 sulfhydryl groups to bind tightly to mercury. It can enter cells, but it cannot cross the blood-brain barrier. It's administered IV. Up until recently, we were able to use it orally, and we would use it topically with glutathione. The FDA decided to put the kibosh on that. They didn't like the idea of us treating autistic kids with topical DMPS and glutathione to remove the mercury that caused their autism in the first place. So now we can only use it IV, which is a shame. And of course, we're going to give you the vitamin mineral supplements because we know that if you have an oxidative, if you have an excess of free radicals, we want to support your innate antioxidant defenses. We want to squelch this free superoxide and peroxide. So a broad spectrum vitamin and mineral program, and the greater your degree of oxidative stress, the greater will be your requirement for nutritional support. So how does this all work? Here's the cell of a sick cell. It's got some plaque. There's more calcium than magnesium in the cell. There's not a lot of good nutritional minerals, antioxidant minerals, and there's this toxic burden. So we're going to administer IV EDTA bound to magnesium. So it hits the circulation, it'll let go of the magnesium and bind calcium. So what'll come out is EDTA calcium. It will also bind toxic metals. So EDTA cadmium, EDTA iron, EDTA lead goes out. We're treating you 2 to 4 times a month. On the off days, we're going to give you nutritional minerals because we know you're low. So basically, after the first chelation, there's a little bit less calcium and a little bit more blood and a little bit more good minerals in the blood. And that night, calcium will leave the cell and come into the circulation. Toxic metals will leave the cell, come into the circulation. The good metals will go in. We do this over and over and over again, checking upon you periodically. Eventually, we got this situation where your cells are healthy. They have an appropriate ratio of magnesium to calcium. All the toxins are gone. You're full of good antioxidant minerals. This is what Mother Nature intends, and we're going to dramatically lower the degree of oxidative stress. And if we lower the degree of oxidative stress, we're going to have benefits in cardiovascular disease and in kidney disease. That's all that we're doing. There are non-pharmaceutical chelators. I use pharmaceutical chelators because this is what I've been trained to do, and this is where I have a lot of experience. And we'd love to be able to do this with food and herbs, but we can't because these are man-made toxins and they really require a man-made solution. Now, there are nutritional non-pharmaceutical chelators available that we will use. They are not as powerful. Now, I will often use phosphatidylcholine with EDTA. Neither of these are well absorbed, but you whip them at high speed and you make them into a liposomal-like structure. And this is a way of getting phosphatidylcholine and EDTA into the circulation of the cells, and we use that a lot. The trade name there is Detox Max or Lipophos EDTA. Enteric-coated phosphatidylcholine EDTA. Oral EDTA is poorly absorbed. It's degraded by stomach acid. So we created an enteric-coated phosphatidylcholine EDTA called Med5, and we have a patent for oral EDTA, and my name is on the patent. And thus, if you're my own personal patient, you can get Med5 at a huge discount, so I don't have a conflict of interest. So we created this as an alternative to IV chelation, and it's not particularly expensive. I don't think it's as powerful as IV, but it's certainly better than doing nothing. And if you take this long term, if you take these oral agents long term, eventually you're going to get the same result as with IV. It's just not as rapid or as efficient. Pectins will bind metals. The Battle Plan, my buddy Robert Battle in Houston, who's just a really great guy, he has a program, a nutraceutical program, Algus, NDF, chlorella, and glutathione to remove mercury. Zeolite is a crushed rock that is very, very porous, and if you take zeolites, it will bind metals. There's an enteric mercury binder called IND or Quicksilver that we can use. Lee Cowden has an energetic methodology called laser energetic detox that stimulates the body to remove metals. We have the digital homeopathic patches. These probably don't remove metals, but they are felt to electrostatically neutralize the toxins by interfering with their electrostatic charge. That's not something you can prove, but it seems to help. And then detox upregulation supplements, supplements to increase metallothionein and NRF2 translocation and to increase glutathione. We'll use that. Detox medical foods to get rid of organic pollutants and to help with metal toxins. So we'll use all the above along with IV chelation with pharmaceuticals to get as much toxicity out of your body, metals and organic pollutants. And of course, we're doing this because we want to deal with oxidative stress. So we'll measure oxidative stress. We're going to keep working with you, and we're going to resolve the oxidative stress because an excess of free radicals is going to tip you over and lead to oxidative stress, which is the kindling in the bonfire of atherosclerotic inflammation. These are the references for the modern day IV EDTA controlled trials. Now, TACT 1 was a success, and the NIH and the FDA said, yeah, it worked, but you got to repeat it because they make big pharma repeat everything. Now, this is kind of stupid. It's a delay tactic because nobody wants EDTA to be in the hands of primary care doctors. Because once this occurs, and your insurance company start paying for it, anybody in their right mind is going to go, yeah, I want to get chelation therapy. I want to get these poisons out. And this will dramatically decrease the professional activities of cardiologists and nephrologists, and it will compromise the economic status of the entire medical industry. So they want to delay this. I think this is wrong. I just think it's plain old irresponsible, but the excuse is they make big pharma do it twice, so we're doing it twice. So this is TACT, try to assess chelation part 2. We're going to do this, the same study, except in diabetics. You're going to get chelation and a multivitamin. You'll be in the 1 of 4 groups. We're also going to measure your baseline lead and cadmium level. And our theory is that those of you with greater burdens of lead and cadmium, you should get a more powerful chelation effect than those of you that have less. So if you have had a heart attack and you're diabetic and your kidney function is reasonably well preserved, you can participate in TACT 2. Half of you get the real deal, half of you get a fake. Neither you or I or anyone in my office knows. We're all blinded, and we're going to treat you. You'll get 40 treatments, and then we're going to follow you for 5 years. Most of this is a telephone follow-up, and we're going to show that, again, chelation works. And then the NIH and the FDA will not have any excuses, and they will approve chelation, and then Medicare and insurance companies will cover it. And I hope to see this before I retire. To learn more, physicians can be trained in chelation, and the teachers of these workshops are people like me, including me. I will participate from time to time in the American College for Advanced Medicine and the International College of Integrative Medicine basic and advanced chelation therapy workshops. I teach in the fellowship in anti-aging and regenerative medicine, and doctors can become TACT 2 principal investigators. And in this process, you'll learn a great deal about chelation therapy and heavy metal detox. I'd like to close with a shout out about Theodore Roosema. When I took the chelation course several decades ago, it was directed by Dr. Roosema. This was the best course I ever took. I learned not just about metals and oxidative stress. I learned about lipoprotein A, fatty acids, homocysteine. It was great. And Ted was in charge of the program. And I got to know Ted, and Ted took me under his wing because he sensed that it would be very difficult for me as an invasive cardiologist to get involved in chelation therapy. I'm the first cardiologist in the state to get involved in chelation therapy, and he was right. It was very, very difficult for me to take this position and stick with it. So I talked to Ted all the time, and I learned a great deal. When Ted taught us, he said, we have a long road ahead of us, but we're doing the right thing for the right reason. And over time, chelation therapy will catch on. More and more doctors will get involved, and eventually we will have government funding for a study. Now, to prove anything to the FDA cost a minimum of $30 million. And the trial to assess chelation therapy was funded by the government, and it cost $32 million. And Ted predicted this correctly, and he said the government at some point is going to get tired of spending billions and billions and billions of dollars on dialysis and bypass surgery that are the consequence, at least to some degree, of metals, and they're going to say, yeah, study this and show us that it works, and eventually they'll cover it. And Ted was right. Now, Ted passed away recently, but not until the trial to assess chelation therapy was published. And Ted was the driving force. He and Dr. Lamas wrote the protocol. So this guy I admire an awful lot. Lots of strength, lots of brain power, and by teaching me and teaching thousands of other doctors, think about all the lives that he touched. So Ted, you're up in heaven looking down on us. You did a really good job, and it's up to the rest of us to carry on your good work. And that concludes our presentation, the role of toxins in cardiovascular and renal disease. I thank you for your attention.